Okay, so I'm going to pick back up on DIC. This is part 2 of chapter 6. So make sure, Wink and Lollipop, that you understand this nursing care. So they're going to be bleeding from every orifice, even their eyes, nose, ears. It's really, really bad. They have petechiae oozing from injection sites, hematuria, everywhere. Okay. And then there's some triggers. So over here, placental eruption, HELP syndrome. So when you get HELP, you could further get DIC. Sepsis, retained intrauterine fetal demise is what IUFD is. Amniotic fluid embolus. Okay, so I'll pull up this PowerPoint that I made. This is just my notes PowerPoint, if I didn't make that clear in the first ones, but I'll pull this up in class where you can see it if you want to. But there's just some risk factors: low risk, high risk, some obstetrical risk factors, and we just talked about that. Acute fatty liver is on there, placental abruption, of course. So, and then abruption. So DIC occurs 4 to 10% of the cases, and usually is apparent by 8 hours after the onset. And renal failure is the most common cause of maternal mortality, because of course, if there's no blood, there's no perfusion to those kidneys, they start shutting down. Okay. And then this is in your book. Let's see. On page 264, you can flip there if you want to, but we'll go back and talk about that in a little while when we get to those. In that, whatever chapter that is, I think it's chapter 8. Yeah, chapter 8. And it'll cover DIC, so when we get to chapter 8, you'll see this again, but I just wanted to refer to it now, where you can see that. But these are just, of course, the lab diagnostic test, okay? And I'm going to give you a copy of this. This is comparison of HELP and DIC. It's really good to understand it, so I'll give you a copy of this handout here, though. All right, now we're going to start talking about multiple gestations. So this is on page 164 still. Multiple gestations, or multip, you may hear it called, multiparous, refers to 2 or more fetuses that are in the uterus, okay? And there have been cases where there's 2 uteruses. Very, very rare, but it does happen. And you can see the statistics here from the CDC. The different types of multiple gestation. Monochorionic is 1 chorion and 2 amnions, okay? So you will see that on A. So there's 1 sac, but on the inside there's 2 internal amnions, 2 internal membranes, okay? And they share a placenta. And then you have the dichorionic, which are 2 chorions, 2 placentas, 2 sacs, 2 amnions, okay? So just be familiar with that. Conjoined twins is where their bodies are joined in utero. They share everything, obviously, and you've seen cases of that, I'm sure, on the news and all that. Over here are the same pictures, and this is the RH factor. So let's talk about this. Trying to find the page it's on. So this is on page 170. We'll get to that in just a second. So let's look at page 166. UTIs. So you know, of course, during pregnancy, UTIs are very, very common. For all types of reasons, okay? Bacteria, cystitis, pyelonephritis. It's just something that happens because of there's so many changes, hormonal changes, the moisture in the vaginal canal can go up through the urethra and cause bacteria. So for UTI, it's the most common bacterial infection, of course, during pregnancy, okay? And then there's one that's called pyelonephritis, okay? So pyelonephritis has 4 bullet points that I want you to know. So you should write these down. Wink and lollipop, okay? So pyelonephritis, you see the word here, right? Pyelonephritis. You're going to, number 1, assess for sepsis, which includes increased respiratory rate, increased temperature, and chills. Number 2, monitor the output. Number 3, monitor for contractions. And number 4, administer ceftriaxone, which is Rocephin, okay? Ceftriaxone is CEFTRIAXONE, and that is Rocephin, okay? This is a bacteria that gets in the kidneys, causing extreme discomfort, extreme infection, and it can cause even kidney loss. So make sure that we stay on top of that during pregnancy. Any type of UTI can turn into pyelonephritis, so we want to get those UTIs treated, okay? Lots of mechanical and hormonal changes. So make sure you understand that. So I'm going to say the 4 things one more time. So for pyelo, assess for sepsis, which includes increased respiratory rate, increased temperature, and chills. Number 2, monitor for output. Number 3, monitor for contractions. And number 4, you're going to administer ceftriaxone, which is Rocephin. Okay? All right. Moving along. We'll come back to this picture. Group B strep, coccal infection, GBS. This is what this is, GBS, okay? This is a common infection in many women. It's a natural flora bacteria that lives in the vagina. It does nothing to the mama. It does not make the mama sick. It's kind of like if you have freckles or you don't have freckles. It's either there or it's not. It's nothing that the mama did to get GBS, but it can make the baby very, very, very sick. I had a case where a family practice doctor delivered a baby at another facility, which was a level 1, and gave actually Rocephin instead of ampicillin. You have to give a penicillin or Ansef if they're allergic to that, because that's the only drug that is going to treat this group beta strep, okay? Rocephin does not cover it. So instead of giving the drug that he was supposed to give, he gave Rocephin instead of ampicillin or Ansef. And it did not cover it. The mama was GBS positive. It did nothing to her, but they shipped the baby to us. The baby coded 3 times on me before I could ship it to a higher level facility. Very, very sick little girl. Very sad, because it could have been prevented. It's infuriating that there's incompetent providers that do not do what they're supposed to do, and it costs lives. So that was a day I was working in the NICU, actually. So make sure you understand that ampicillin, and if they're allergic, you give Ansef, covers GBS, nothing else, okay? So at about 28 to 32 weeks, they're going to get tested, okay? They're going to get tested. They do all the swabs. GBS is a swab that they go from the vaginal canal to the anus, and they swab it. It's just like any other culture. It grows 48 hours, 72 hours. It comes back. You're either negative or positive. But you need to know, once they're positive for GBS, they're always positive. So on their first pregnancy, if they tested positive, their second pregnancy, there's really no need in getting another swab because they're going to treat them anyway. So once they're positive, they're always positive. They'll always get antibiotics during their labor. Okay. I was GBS positive. Happened to me. Like, I got it with my first one. They didn't even bother testing me with number 2 and number 3 because I was positive in the first one. So I got the ampicillin. You have to get the ampicillin. You need at least 2 doses while you're in labor. Okay. All right, but it is a right here, penicillin-based anti-infective agent is what it's treated with. Okay, so please understand that you need to know that. All right, torch infections. Big thing during pregnancy can happen. It is a group of infectious diseases that can harm the fetus. Okay, it stands for toxoplasmosis, rubella, cytomegalovirus, and herpes simplex 2. Okay, the O, of course, is for other infections. So look over here, and you will see what all it stands for. So other is syphilis, parvovirus, B19, varicella, which we know is what? Chickenpox, listeria, rubella, and then it goes down through the torch. Okay, so it's vertically transmitted through the placenta, through blood, body fluids, or breast milk. Okay, and we will watch this video in class. All right, so please understand that torch is a big thing during pregnancy. It can happen, and that's what it stands for. So just understand all of these. All right. HIV and AIDS. And then on page 167, there's a whole chart, table 6.3, that is covered, okay, on torch. HIV and AIDS, just read through that. I think you're all familiar with that. Of course, we want mamas on their antiviral medications. And then, of course, our fetus goes on antivirals for up to 6 weeks after birth to make sure, but they're all, of course, they're tested and everything, okay? Mamas should be counseled before they get pregnant, during pregnancy, and after, okay? They don't need to be breastfeeding. They get C-sections, so read through that. And this is the torch. All right. 168 talks about lupus. We're not going to really talk too much about that. Just read through that. And then this RH, okay, this is important. So if you go back right here, this picture is on page 170. So the pathophysiology is explained here for the RH. So it's a condition that the hemolytic disease of the fetus and newborn is a condition in which the lifespan of the fetal or neonatal red blood cells is shortened by the action of the maternal antibodies against antigens present on the fetal and neonatal red blood cells. Okay, so it's where the mama's blood fights the baby's blood. Okay, so please understand that section. Alright, so the fetus must have positive RH factors, and the mother has negative. Okay, so it's when the mama's blood is fighting the baby's blood because the baby is positive and the mama is negative. So if the mama's O negative and the baby's A positive or O positive, it's going to fight. Okay, and we're going to talk all about that. Look down here. This is another winking lollipop. So when they're present in the mama's blood, the mama is sensitized. They freely cross the placenta and start destroying the baby's blood. Over time, the baby is red blood cell deficient, and their bilirubin starts rising. It's severe neurologic disease can happen, encephalitis of the brain, all that can happen. It's rapid. Erythroblast, which we know are what? Immature red blood cells, start to develop, and they just can't keep up with what oxygen needs to be delivered to the fetus because they're immature, okay? You have fetal anemia, generalized anemia, which is hydrops fetalis, and it can lead to the fetal congestive heart failure, okay? We give a drug called RhoGAM. It's actually a blood product, RHD immune globulin, okay? And it works because we don't want this to happen, right? It works when we give it to the mama during her pregnancy, and then within 72 hours after she delivers. So she gets it twice. And every time she gets pregnant, she gets this, okay? So we ensure that this breakdown, the fighting of the blood types do not happen if she gets the RhoGAM, okay? If she does not get the RhoGAM, we can have a sick baby and a sick mama, okay? Because their blood starts fighting each other. So I want you to read through that, make sure you understand it. And then here's the picture. So if we have an RH positive dad, RH negative mama, then we're going to have some antibodies here, okay? The baby's going to probably have some positive blood type, okay? So simplifying it, here's an example. You can read through this. It would be great for you to know box 6, 9, okay? I'm just going to highlight, yep. And then, let's see. Go back up here. Make sure I highlighted everything you need to know. Yep. So you can also, for right here, refer to page 291. It talks about it as well. Alright, so now let's talk about Coombs, and I'm going to give you a handout for that, okay? This is that box 6, 9, okay? So this is our RhoGAM that we talked about, the immune globulin, okay? And then I'm going to give you a handout that talks about the Coombs. So let's go down here and find this section. Right here. Alright, so during the prenatal period, any mama that's A negative, O negative, B negative, AB negative, any negative, they're going to get this, okay? There's something called an indirect Coombs test and a direct Coombs test. Wink and lollipop, okay? So the indirect Coombs, it determines whether they are sensitized from a previous exposure to Rh positive blood. If the test is negative, another antibody titer is done at 28 weeks to rule out sensitization, and it may occur later during pregnancy. So if they have a miscarriage, any miscarriage, any what we call spontaneous abortions, they're getting RhoGAM, okay? So because they're still maybe exposed to positive blood. So just because they don't carry the baby to full term, they have a miscarriage or stillbirth, they still get the RhoGAM with every single pregnancy, whether it's viable or not, okay? Alright, so I want you to know the action, wink and lollipop, the action of RhoGAM prevents it from the Rh negative that were exposed to Rh positive, okay? And when do they get it? So, another wink and lollipop, route and dosages, okay? So at 28 weeks, and then 72 hours. So I said between 28 and 32, the book says 28, okay? And within 72 hours. So if they go into preterm labor, what do? You get it as soon as they start preterm labor, okay? If they are before 28 weeks, all right? Because we don't want a chance of something happening. They deliver before getting that ROGAM, okay? 50 micrograms within 72 hours, and then it talks about it right here. All right, management. Just read through this. Now let's talk about the other parts. Okay, so ABO, another winking lollipop. Still talking about the Coombs test. Okay, know this paragraph. You need to know what direct and indirect Coombs are. Okay, direct is when the presence of antibodies in the neonate's blood, or hemolysis, which is what? The breakdown of red blood cells. You remember that term? Lysis, hemolysis, the breakdown of red blood cells. Whereas indirect detects the antibodies in the mother's blood. Okay? So direct is straight from what? The baby. Indirect is from the mama. Okay? So good. Direct is straight from the baby. Indirect is from the mama. Okay? And we're going to see that hemolysis because our baby will be jaundiced because of the breakdown of the bilirubin. Breakdown of the hemolysis becomes what? Bilirubin. Bilirubin makes the skin what? Jaundice. Okay? Alright, so write that down. So a positive indirect Coombs equals jaundice. And that's a byproduct of red blood cell hemolysis that becomes bilirubin. Okay? So again, winking lollipop, know this right here. Know that a positive indirect Coombs equals jaundice. And we know that's a byproduct of bilirubin making the skin yellow. Okay? Diabetes in pregnancy. Let's talk about this. So there's all kinds. There's pregestational diabetes, which is characterized by high sugar, and then you have type 1 and type 2. So you can have a chronic, just plain out, I'm a diabetic and I got pregnant, or you can have something called gestational diabetes, where the pregnancy itself makes the mom diabetic. Okay, there's different risk factors: older than 25, obesity, insulin resistant, PCOS, history of pregnancy-related diabetes, history of LGAs, large for gestational age infant, hydramnios. It's probably like polyhydramnios, which means a lot of amniotic fluid, stillbirth, family history of type 2 diabetes, and ethnicity. Make sure you read through all of this. There's one thing here, winking lollipop. So you need to know what percentage of the A1C should be. Okay, so 8% on a hemoglobin A1C is poor diabetic control. You get diagnosed with gestational hypertension. So they usually do the 3-hour glucose tolerance test, where they drink the nasty syrupy sugar and to see how the baby or the mama tolerates it. And it's broken down right here. Okay, so this is our GTT 3-hour glucose, and these are the levels that we're looking for. So 2 or more values in these that are above the norm is indicative of the diagnosis of GDM, which is gestational diabetes mellitus. Okay. Know this chart. Okay. Winking lollipop. And this is just a little acronym RISK that talks about recognizing leadership, infection control, structure, evidence-based practice, and know how to incorporate is there if you want to use it. Flushed I like's better. The different signs of hyperglycemia, and then tired hypoglycemia. So really good little acronyms down here on what to do. Okay, and then fetal is there as well. There's some more here just about the diagnostics, and this is talking about NST, so we'll talk about that in a second. Alright, insulin and oral hypoglycemic therapy. So you need to know, Winking Lollipop, what percentage of pregnant women become insulin dependent during pregnancy? 20%. Okay, require insulin to become euglycemic, which is normal blood sugar. Okay, if a fasting is over 105, then insulin therapy should be initiated. Alright, so let's move to page 177. It's talking about some other things you can read through. I'm sure you're going to cover all this, or you did cover all of this. We'll cover all of this during mental health. That you got in transitions or 1950. So let's talk about biophysical profile. Okay, so this is an exam, which is just a fancy word for an ultrasound that measures 5 different things during this ultrasound. Okay, you'll see these when we go to clinical. You'll see the biophysical profile BPP reports. It's non-invasive. It's just an ultrasound. Okay. Findings that are scored: normal findings receive a 2, anything abnormal gets a 0 or a 1. A score with 8 out of 10 is indicated as satisfactory. So you can just read through this, okay? But you will be seeing this in clinical. Now, non-stress test. Non-stress test is a common screening that we do for the fetal well-being. It explains it over here. So we want a reactive non-stress test. A non-reactive is abnormal, okay? And we're going to talk about this. This is important. Winking Lollipop, you need to know this chart, okay? This chart is a Winking Lollipop. You need to know how we're measuring, okay? So we're measuring the non-stress test, which means there's 2 or more A cells greater or equal to 15 by 15. And we'll talk about this in class. So 15 by 15 is, it goes 15 above the baseline of the fetal heart rate, and then it lasts for at least 15 or more seconds in a 20 to 40 minute time frame. So we want 2 or more of those, okay? Fetal breathing, is it rhythmic? Can you see the chest rise and fall on the ultrasound? Fetal movement, so we want the baby to be moving. Fetal tone in the extremities, okay? Are they flexing? Are they pulling up their legs and moving their arms? And then our amniotic fluid volume, okay? We measure that as well. So this is how they get a good score. 0 is here. Usually that's 0 or 2. Every once in a while they'll put a 1, but it's usually 0 or 2. So then we have something called a contraction stress test, okay? And there's this chart over here. I think that's it for the PowerPoint. So contraction stress test, it evaluates a fetal heart rate response to uterine contraction. So usually what we do for the non-stress test is they go and they have this little button that they click. And every time the baby moves, they click a button, okay? There's a procedure on page 179 right here. You can read through this. So you ask her to void, she gets some semifallers, we put the monitor on her, and every time she feels the baby move, we get her to click a button, okay? And contraction stress test is we do something to actually augment or start the contractions, okay? So it's based on the fetal oxygenation to see how the baby's doing. We may do nipple stimulation because in a woman's breast they have natural oxytocin, which is pitocin, and stimulating those nipples with a washcloth or getting the husband, whatever, you stimulate the nipples and it activates the oxytocin. Okay, sometimes we will start a low dose pitocin on a drip to do the contraction stress test as well. Okay, we don't want any fetal heart rate deceleration during any contractions that she may have that we're stimulating. We do these tests to see how they will tolerate labor, how the baby will tolerate labor, how the fetus will tolerate labor. If we have a fetus that's in distress and we are worried about are they going to stay accelerated, the fetal heart rate's going to stay accelerated during labor, then we will do a CST, a contraction stress test. Okay, so write this down. I have a little chart. NST, good is reactive, bad is non-reactive, and that's for an NST, non-stress test. So good is reactive, bad is non-reactive. Now for a CST, a contraction stress test, good is negative, bad is positive. So good is negative and bad is positive. So in this chart you need to know wink and lollipop again, okay? And it talks about a reactive test and a non-reactive, okay? So know the difference, wink and lollipop. And then the rest of this is just special considerations, so you can read through the rest of this chapter. All right, that's it for chapter 6.